I am Jed Connolly-Thompson. I am the next slide. See, I'm Head of Digital Development and Information Governance for NHS Derby and Derbyshire Integrated Care Board. And on the call with me today, I have Liz Rees, our Head of Business Intelligence. I have Joanne Goodison, one of our Senior Commissioning Managers, and I have Hills Poole, who provides IG support into the organisation. So briefly, the topics we'll be covering: use of patient identifiable data to provide care. That's across the system. As kind of an introduction into direct care and how we use data for direct care. Then we're looking specifically at how the Integrated Care Board uses patient data currently for risk stratification, what this means and how that works, and also a bit of future planning for population health management, but we don't currently use data for that. But there are plans to look at doing something in the near future. Hot topics are including Palantir and federated data platforms, so we won't be covering that today. We won't cover any access to primary care services queries, and also prospective access for patients to primary care health records won't be included. It's mainly looking at the data that flows in the system and specifically how the Integrated Care Board uses patient data to enable it to fulfil its statutory obligations. So starting on with direct care. So as you may be aware, each GP practice in our primary care system has access to a clinical system, and any interactions you have with the GP practice, this information will be recorded. If you need to be referred to another organisation for whatever reason, then that organisation, to ensure they provide appropriate and safe care for you, will receive either a full medical record or parts of your medical record to give them some kind of context around that, so they make sure that it is perfectly safe. There also information about you may be shared with things like the Derbyshire Shared Care Record or National Summary Care Record, and again, that's for people who have a direct care relationship with you. This is someone involved in your care, specifically who you have an ongoing relationship with. There's no further sharing outside of that. And in terms of risk stratification, so this is also direct care, but it's a different kind of direct care. So this is information that comes into the ICB, which allows us to run certain queries and identify certain patients who have a high risk of developing or have the potential to develop a worsening health condition in the near future. So some examples there on the page. It could be that there's the potential to be pre-diabetic. It could be that there's certain tests that you would need. It's making sure that we try to identify and prioritise those patients who have a higher need and that resources are focused towards them. So this is information is gathered from a number of organisations, Derbyshire NHS organisations, and pulled from the primary care record, and it's brought into a secure database. So the information that we see is not identifiable. We're not aware it's you. We look at patterns and trends, and we can see the bigger picture. So we can see, for example, in a certain area, there may be a population who looks like in the coming 6 to 9 months may be at risk of developing a certain comorbidity or getting a certain diagnosis. And so the idea is that our business intelligence team and others in the ICB would run queries inside the radar application, which supports our risk stratification work, and that would identify a number of patients who need to be seen by primary care. These are then shared back to GP practices in primary care, and the GPs can then re-identify their own patients. So the GP will be sent a list which is anonymised to us. We don't know that it's you. We just know that, for example, there's a certain number of patients in this area that we think require some additional support. And when that's sent back to the GP practice, it's your GP who can re-identify, and they can only see their patients. They can't see other patients, so your information will not be shared by any other with any other GP practice. It's purely the GP practice that provides your care. And a worked example, if I can ask Joanne, take us through this. So there's a worked example in terms of how risk stratification has worked recently within the ICS.
Yeah, as part of the work that we do around CVD prevention, some work that we wanted to do in order to sort of help primary care to sort of risk stratify and prioritise the patients. We worked with a provider, UCL Partners, which is a health innovation organisation the NHS work with. And they've developed a series of sort of proactive care frameworks that support primary care, as I say, to risk stratify the patients. They do it for sort of several long-term conditions, but as part of the CVD work, we looked at hypertension. So we worked with the ICB medicines management technicians that work within practice to carry out some of the risk stratification and prioritisation of known patients with hypertension, high blood pressure, also atrial fibrillation and elevated cholesterol. And that was basically, a search was developed to sort of upload onto the clinical systems, either System 1 or EMIS, to carry out searches of the sort of hypertension registers, the existing hypertension registers, and look at the patients that are stratified into sort of priority groups. And it was based on the last recorded blood pressure, as well as comorbidities and ethnicity. And as I say, that grouping allows all practices to prioritise the patients, to sort of safely sort of phase review appointments over time, either with a sort of prescribing clinician or a healthcare assistant. So there are other providers and practices use different risk stratification tools, but for this purpose, what we thought we'd do is to, as I said, utilise UCL framework. And so, as I say, it's divided into 4 priority groups, and that's really sort of based on the sort of BP reading. So, for example, priority group might be a patient with recorded blood pressure reading over 180 over 120, and for priority 2 it'd be 160 and 100. And as I say, there's a sort of risk stratification pathway to support primary care. And as I say, this information is just uploaded onto the clinical systems and only primary care can see that, and it allowed them to prioritise the patients. And as I said, it's sort of that they can match the patient care to the relevant workforce depending on the priority groups. So we did that, as I say, our medicines management technicians did that in summer this year, and we let each of the practices know that that was available. Thank you.
Thanks very much. Unfortunately, there's a fire alarm going at Scarsdale. So, Hills, could I ask you to pick up some of the presentation from there? Would that be okay?
Yeah, absolutely fine. I'll carry on, Jed.
Sorry. I'll join when I can. Sorry.
So Jed's at Scarsdale. The only thing I don't have is the slides, unfortunately.
Mark, do you have the slides available?
Oh, hang on. Let me go back in. Liz, do you have them in the chat from the link that you sent me?
We should have just put some Christmas tunes on today, shouldn't we? Just had a bit of a sing-song.
Hang on.
Having a look, because I know I sent a link. You got them?
Just do them. Here you go. Two minutes, it's just opening it. Yeah. So then, let me see if it lets me. It's loading the presentation, so we'll be there with you in a second.
Is it loading, Hills?
It is. I'm just trying to share. I think it might end up sharing more than just one slide, but let me just see. Can you see that? There we go.
Yeah.
Let me just, is that?
Yep, we can see that.
Yeah, for
great.
you.
Yep.
Let me just whiz through and we'll get to where it got to. So our regional processor, Jed mentioned in the slide a couple of before the example that we've just had, that information comes from different sources and goes into a secure environment for some of the risk stratification tools to be applied to. So we have an organisation that does that for us is an organisation called the North of England Commission and Support Unit, NEX, and they're an accredited NHS safe haven organisation. So your data is held in a secure environment with kind of appropriate levels of security and access controls. There we go. Next slide. The point of risk stratification is that, or the key points to consider is that that organisation, so NEX, who's our regional processor, removes all of that identifiable data so that people who don't need to see the identifiers, so people like the Integrated Care Board, they don't need to see who the information is about, but they need the ability to put different elements of data together in order to be able to apply the risk stratification tools. No one within the Integrated Care Board, the ICB, can identify you as an individual, but by providing the data in that environment, GP colleagues, for example, are able to re-identify you so that they can deliver that direct care. They can identify that group of people that actually are in that priority group who would benefit from an intervention. They can then provide that care and support without having to go into their own systems and try and pull different bits together from their own system. The risk stratification tooling that we have does all that for them to make it much easier and much more efficient, a much more effective and robust way of doing it. The information isn't used for any other purpose. It's just used for this purpose. And we've applied to an organisation called the Health Research Authority, who kind of help the NHS to govern how we use patient information. So we completed an application and we've applied to enable us to use the information as we've described for this purpose. Are there any questions on that bit before I go on? I won't be able to see hands or comments or anything.
There's no hands up at the moment and nothing in the chat, Hills. So yeah,
I will
think
carry
move on. And we can pick anything up towards the end of the presentation as well.
Brilliant. So the next part of this kind of presentation is about population health management. So pop health management is different to risk stratification. The risk stratification stuff is all about being able to, once you've understood and kind of grouped the data to enable us to look at kind of the critical needs of individuals to be able to deliver care or an intervention. Population health management is a different kind of approach. So this has been around for quite some time, and it takes information about different aspects of an individual, but at a population level. It's about looking after kind of neighbourhoods and areas, and those areas can be on a geographical footprint like Derbyshire. It can be on a regional one across the Midlands region, which is our NHS region, or it can be on a broader scale nationally. It takes different factors and considers different things because health, there are what's called wider determinants of health. Your health isn't just necessarily about your physical health. It considers the things that can impact on that. So things like employment status, income and wealth, education, housing, living conditions, even the amount of green space and interaction you have with people in your community. So all of those together give an understanding of the health of a population. So it looks at an overall population group, and the aim of it is to look at prevention rather than treatment. So risk stratification is about trying to help identify people who have a health need that needs a treatment, a targeted thing right now. Whereas population health is about how we manage the conditions that wrap around the people within our area in order to kind of prevent a condition from being generated in the future. So knowing the health and well-being of our population involves data that needs to come from different organisations. So things like education information is held separately to the NHS, for example. In order for us to be able to undertake the requirement to do population health management, then we have to have the ability to share data from different organisations about our population. But it's not about understanding the individual people. It's not about understanding what's happening with Bob, for example. It's about understanding what's happening to individuals without us having to know who those individuals are. And it's not quite the same as public health, but if we have questions about that one, we can pick that up later. So there are 4 pillars. Population health management has 4 pillars to them. There are wider determinants of health, which is income, education, your residence, that kind of thing. Health and behaviours, that's things like smoking, the amount of exercise we do, how much alcohol we drink, places we live in and the communities we live within. So we know that that has quite an impact on things like mental health. So the amount of green space that surrounds areas where you live, the ability for people to stay in their own area as they age, so they don't have to leave their own kind of place and neighbourhood in order to live safely as they get older. That kind of thing is the third pillar. And the fourth one is actually about organisations across the system being able to work together, rather than thinking, for example, that hospital just deals with the patients that need them at that time. Actually, it's about the requirement for all of the organisations that support the population. And that could be the county, the voluntary sector. It includes health and primary care, but it involves community services, mental health services. It's a much bigger kind of system-wide approach to how we look after and how we will look after people going forwards. So one example for is housing development. So a population health management approach to housing development would consider things like how easy it is to travel from where the housing development would be, whether or not there are routes where you could walk from where you are to shops and all sorts of things like that. So it wouldn't, for example, require you to have to be able to drive to be able to get from where the housing development is to be able to access services, that kind of stuff. The green space that would surround it, the size and design of individual homes. So that obviously there's the feeling of space and they're not all kind of crowded together, that kind of thing. Ensuring that the homes in those developments are accessible to everybody within those sections of society. And as we mentioned before, allowing residents to remain within their homes as they age. So the key differences between the risk stratification stuff and the population health management is to do with the identifiable data. So population health management, we don't need to see the data about the data that would be linked to and identify me as Hills. It would be about the information relating to me without anybody knowing it was me. There is a requirement, so when they changed the Health and Social Care Act in 2022 to generate what are now integrated care boards, and they made integrated care systems a statutory body. So that's the group of organisations that work together to look after, in this example, Derbyshire. We are required to undertake population health management, because that's one of the ways that in the future we'll be able to limit, if we get population health management right, we'll be able to limit things like cardiovascular disease in future years. Phew, and there we go. I'll stop sharing my screen.
Thank you, Hills.
I've now frozen, haven't I?
Oh, it's okay. I can see everyone. So yep. Thank you very much for the presentation. Really great to see some really good examples there, and sort of to bring it to life a bit more in terms of the cardiovascular disease that Joanne talked about, and then Hill's talking about the housing development. I feel like I've learned a lot about risk stratification and population health management in that as well, so that's really great. I don't know if anyone's got any questions. I can't see any in the chat at the moment. I don't know whether anyone wants to raise their hand to ask anything. Richard, would you like to ask a question? Oh, I can't hear you. I think you might be on mute.
I'm off now.
Oh, brilliant. Yeah, I can hear you now.
Do the people who live in these dwellings, do they have any degree of say in the management? I mean, I obviously live in a leasehold property, but we do have a manager, and the organisation that owns the infrastructure does have a forum. Now, I don't really know whether we can greatly influence the style of housing, or to what pressure we could put on the landlord to change the things that make healthier living. I did notice that you're saying that people should live in their property until they age. In fact, most of them actually run away when they get old. There's a tendency not to die at home. Although I believe, if I remember my paperwork from earlier on, that was one of the ideals, that people should choose to die at home. I can say that our oldest resident is 100. I'm in the 80s, I'm in the middle 80s, and a lot of people around here are well in their 90s. I don't recall any of them saying that they're planning to stop there until the day they die. So are these all fine words? And I wonder where you get all this information from, or how you arrive at this ideal that people want to die in their own homes, when the reality is, if they can afford to move away, they move away very quickly. I can assure you that.
I think sometimes it's two different things. So sometimes people, as they age, there comes a point at which it becomes difficult for them to live independently, and there's almost like a point, isn't there, whereby with support and care and input you can stay at home, and that would be the place people choose to go to. There may well be a physical point at which you can't do that anymore. The need, the safe care for an individual requires more input than, I don't know, 4 visits a day or whatever that might be. I think that's a different ask. The PHM element of that would be being able to look and see, for example, that there are a group of across Derbyshire, I don't know, take a number, 1,500 elderly residents that actually are currently in their 60s, and I guess in 30 years' time we're going to have to make sure that we have the resource, we have the nursing homes, we have whatever it is that we need as a county to be able to manage the care of that cohort of people. That's the kind of thing that population health does, but it takes that information from social care. So of those 1,500 people, it would require information from how many of those at the moment do we think would require care. So of our current population of people in their 80s, is it 50% that need care 3 times a day? I don't know. It takes information and data and helps to start understand where we are now, where we could be if we don't do anything, and then potentially what we could do as a system altogether to enable the kind of care of that group of people going forwards. Does that answer your question? I'm not entirely sure it does. Liz, do you have any better examples?
No, I think you covered it. Sorry, I was just checking I wasn't on mute. Sorry. I keep coughing. I apologise, everyone. I'm a bit of a cold.
Yes. When, as you get older, all of a sudden, your health requirements change very suddenly, don't they? You only need to fall over, as I've discovered, and your whole life changes.
Yep.
You go for a scan, and they say, "Oh, sorry, you've got cancer." And so, right out of the blue, neither you, your GP, knew you'd got cancer. He might say, "Well, I told you to stop smoking," and say, "But cancer is in my leg, doctor. You can't really say you blame my cancer in my leg because I smoked." Are you saying that? Or are you making some convenient assumptions that what I've got is the core, related to some other? You see what I mean? There's a danger, isn't there, of using. It's like diabetes. It's blamed for everything. It doesn't matter what you've got. They say, "Oh, well, you're diabetic." Oh, okay. What's that got to do with the fact that I fell over? Oh, well, your blood sugar must have been wrong. No, it was perfectly okay. I just fell over.
So the risk stratification bit that we talked about first, for example, could look at a few common things, like, for example, if you can see that an individual has maybe attended A&E, not quite with falls that have been hard enough to break something, but actually they've just been a bit unsteady, but maybe they've called for an ambulance a couple of times, they've ended up going to A&E a couple of times. Nothing is quite wrong, but actually when you start putting together bits of information, maybe actually there's a prevention thing that needs to be intervened with that individual to say, actually, maybe they'd benefit from going on a falls program. See if we can understand a little bit more about why they might be at risk of falling, to do something to prevent them actually having a fall that then results in a fracture, for example. That's the kind of thing risk stratification enables us to do, which is really important. That's what gives your clinicians the ability to go and kind of drill down and see information about their people that they wouldn't normally get to see. It brings, so GP doesn't usually get to see information that happens in a hospital. They might get a letter back to say, Fred came and attended minors because he'd had a bit of a stumble and he's got a big bruise, but that's all. And unless the GP has the time and the tools to be able to put different bits of data together, he may not actually realise that Fred is at risk of having a more serious fall. So that's what risk strat does, and that's why the information that we pull together has to fundamentally be about Fred, because we want to be able to find Fred and intervene. We need to do something to help Fred. The population health bit is more about saying, okay, so we've actually got an elderly population who've currently got maybe diabetes as well. Maybe actually they're in smaller sections of the community, maybe they're quite rural. Maybe we need to think about developing some strategy to make sure that we've got our services become accessible or continue to be accessible to that group of people, because they're going to need them going forwards. Or, we're going to have to think about, in 10 years' time, we're going to need a housing strategy that enables this group of people who are currently in their 60s, who will then be in their 70s going into their 80s. They're going to need somewhere to live. Like, either we help them stay where they are, or we'd absolutely deliberately plan environments and places where they can be safely part of our population as they grow older. So that's the kind of distinction which is why the data we need for the population health element doesn't have to necessarily tell us about Fred, but we'd like to know about all of the Freds across the system, all of that kind of thing.
Thank you,
Yes.
Hills, and thank you, Richard. That's yeah, great, good examples again. We've got a couple of questions in the chat, so I don't know, Mark, do you want to bring those in?
Yeah, absolutely, I can. Okay, so first of all, Rachel Shaw has asked, Derby and Derbyshire have the largest deaf community, and she's sure there are many deaf organisations locally. Are they part of your equation to population's health management?
I would assume so, yes. We can double check and make sure, but they would be part of the system partnership that we would expect that has that shared responsibility.
Okay, and the next question from Tom, he says, outside of the national agenda, for example, Core 20+5, what are the ICB priorities for population health management?
That's a good question.
Jed seems to be back now, so I don't know whether you want to hand that one over to Jed.
That's probably a chief medical officer question, I think, in terms of that's more to do with Chris as the exec lead, Chris Weiner as the executive director lead for data. We can take that question away and ask Tom. I don't think it's anything we can answer on this question. This is mainly looking at, I guess, from the patient focus, give assurance around how data flows into the system and that we make sure the appropriate safeguards are in place. Sorry, Liz.
I was going to say, I can sort of say that some of our key areas going forward will be things like maternity and learning disabilities. But yeah, to get a proper confirmation of exactly what the strategy is, we
also have we're also part of some of those core 20+ requirements already part of what Derbyshire's engaged with. So, for example, Jed's leading on the SMI and physical health check programme for the Midlands. Jed's the chair of that, and I think that's maybe the second requirement, isn't it, in Core +20? So yeah, I think some of them will align, and it depends really on I guess who gets to choose that priority. Hence the reason we'll get a more senior response, I guess. Does that help? Does that cover it? I'm hoping yes.
Yeah, thanks, Hills. I wondered, it's been really helpful to hear different examples. I don't know whether you've got other examples of things coming up like Joanne talked about in terms of, you know, areas that you're looking at exploring in terms of the risk stratification and also population health management in terms of the data side.
Is there the proof of concept?
Sorry, Jed, go on, yeah.
Lizzie, we've got the proof of concept work that we picked up because there's a proof of concept for
cancer.
Yes, isn't there?
Yeah, we're looking at doing a piece of work on cancer because it's sort of known that Derbyshire has a higher level of emergency admissions for cancer than other regions compared on a population by population basis. So one of our projects is to sort of have a look at that to try and understand the reasons for that and to work through if there's any suggestions that we can do to help that and improve access to care. That's one of the big projects on the agenda.
Yeah. How would we find out more about some of these things? Is there somewhere we can go for extra information? Is there a web page or anything that we could, you know, the public could look at for things coming up in this area?
Yeah, I think the Staying Well programme have got quite a lot, but we'll send out some links to them and just make sure they get circulated with these.
Yeah, that'd be great because it'd be good to sort of see what's coming up in this area, and then if anyone's got any extra questions, they can obviously ask those through the right appropriate channels. I can't see any more hands up, and I don't think there's any more questions in the chat. So I think we'll close the session a bit earlier today. But I want to say thank you to Jed, Hills, Joanne, and Liz for bringing us really knowledgeable presentation and some great examples in there to talk about how we use your data. So that's brilliant, thank you. And any of those questions, we will, as always, post the question and answers on the engagement platform once we've got some of the responses to those as well. And our next session coming up in January is Wednesday the 24th of January, and that's all about the Derbyshire Living Well programme. So hopefully we'll see you at that session, and I hope everyone has a lovely Christmas and New Year and everyone takes care of themselves. Okay, thank you very much, everybody.
Yeah, take care.
Thanks,
Bye-bye.
Thanks, everyone.
Bye.